Hi, everybody. It's Angela Love-Zarenka, lactation consultant in private practice, as well as hospital-based lactation consultant from Lactation Education Resources. Thank you all so much for joining us today. I have the great honor and pleasure of introducing both Nikisha Killings, Nikki, and Nikki Hunter Greenaway, Nikki, as well as Jada Wright Nichols, who is an occupational therapist and IBCLC. She is the owner of Blossom Health and Maternal Wellness, and she is a lactation consultant at a children's hospital in Atlanta. So I'm going to turn it over to them to introduce themselves even further. And please do write into the question box any questions that you have. I will be keeping an eye on them and monitoring them. And Nikki or Jada will tell me when they are ready to take questions. So,
Thank you. Everyone. Hey y'all, welcome back. All right. Okay, I'll start. As she said, I'm Nikki Killings. I practice lactation consultant in Los Angeles and do community work as well at Lactation Education Resources. I am Director of Equity and Inclusion. It is my honor to be here today. Shout out to LER for making this happen. And my partner, Nikki Greenaway from Nikki and Nikki.
Hello, everyone. I'm Nikki Greenaway, also known as Nurse Nikki. I'm a family nurse practitioner in IBCLC. I am here in New Orleans, Louisiana. I have a private practice where I provide prenatal and postpartum care. I do house calls. So this whole situation has totally flipped us upside down with now moving outside of house calls. So I'm happy to be here and talk to y'all about what we're doing.
And we're so excited today to be joined by Jada Wright Nichols. Can you tell us a little bit about yourself, ma'am?
Yes, hi ladies. Thank you. So happy to be here. I am actually at my hospital right now where the scene and the census and the mood, everything, policies are changing every single day. But this is really an interesting time because my actual first job in lactation was on a breastfeeding hotline where we didn't even have face-to-face, there was no FaceTiming, there were no HIPAA compliant modules to use, platforms to use at that time. So I feel like a little bit now baptized by fire in this now mandatory telemedicine, telehealth age. So it's becoming full circle. I'm doing, I went from breastfeeding hotline, so of course, private practice, home health, breastfeeding, lactation, consulting, and then to the hospital where I'm hands-on with moms and babies. And so having to back off even now at the hospital has been quite interesting. But I think settling back into that comfort of being able to assess and provide information for moms, parents over the phone or using another platform, I think is coming back to me.
Yeah.
Cool.
Well,
yeah,
I'm glad that you're here.
Yeah. Oh, we are very excited to have you here with us, and we thank you for taking the time out.
So we're going to talk a bit today about what it's like to be doing this work right now in the hospital setting. And I think our viewers will have some questions for us. There may have even been some submitted beforehand. But before we get into that, because of exactly what you described, Jada, and I'm sure what Angela's experiencing, what Nikki and I have been talking about, kind of offline, because of where this has us all emotionally, mentally, I just want to take a minute to just kind of check in with ourselves. And our viewers, listeners, please feel free to check in as well. Let us know how you're doing, what you're doing to take care of yourself in this space, in this moment in time, and how you're making it work so that you can continue to be a support to others. Anybody want to jump on that first?
So like I said, I'm in New Orleans, Louisiana, and I've actually received a lot of phone calls from my peers around the country. So thank y'all so much for checking in on us. We are, it is pretty dire here. We've been hit, we're trying to figure out ways. We already had a serious homeless issue here, and now we're trying to figure out what does telehealth look like for a homeless population, and then what does telehealth look like for a homeless population that is about to give birth or just had birth. So that has been a challenge. We just opened our new hospital here at the convention center. We converted our convention center. So if you've ever been here for Essence Fest or any of your conferences, that is now COVID Central, where we've moved folks over there in our hotels. They're housing our healthcare workers and healthcare workers that have come in from out of town, but also healthcare workers that are quarantined. So we have our hotels for that. So it's a every day. I think the insomnia is kicking in. It's been for a week and a half now. I go to bed at like 2 o'clock in the morning, 3 o'clock in the morning, just because, you know, check on your friends who are empaths. We are not okay.
We are not okay.
We are not okay. Carrying these loads that we get daily from things, as Nikki and I were talking earlier, it's like it was like 5 people removed from us. Now it's, you know, 3 people removed. Now it's 2 people. Now it's somebody I know closely. So that's where we are here in New Orleans.
Yeah, we talked last week about how both of us, Nikki and I, are both in major, metropolitan areas that are seen as, epicenters for the virus, but it's going to continue to spread. So everyone will feel this at some point, presumably. Angela and Jada are also in major metropolitan areas. Angela's in the DC area, Jada's in Atlanta. And so whether you all are, slightly behind us, you also will feel this thing. You'll see it get closer and closer. I feel like it's encroaching upon my space. Like, I was telling Nikki, just as she said, like, it used to be, oh, I know someone who knows someone, and oh, my cousin, oh, my in-law. Now it's like my spouse. You know what I mean? It just keeps getting closer and closer and closer. The reports that we're seeing from those around us. And so as that continues to happen, it can feel overwhelming. And we, all of us, I'm sure, are really good at just continuing the course, helping people, and not maybe not so good at stopping and making sure that we are taken care of and that we are filled back up. Jada, you do an excellent job of this. I know because you're into yoga and self-care. But for the rest of us, I think we probably could use a lot of help in that regard. So I'm okay. Check in on your people who are who's just been at home for 3 weeks, just no matter if it doesn't matter, just check in on us. Just be kinder with each other, understand that everyone, if it wasn't clear before that everyone you encounter is going through something, it should be crystal clear now that everyone you encounter, even if it's encountering them virtually, is carrying a pretty heavy load right now and is anxious to some degree about this thing. Right. Jada, Angela?
Yeah, so Nikisha, have you ever heard of the cobbler who has no shoes? I can teach people, I can guide people, I can lead people through wellness and yoga and meditation and breathing, which is so important right now. But my goodness, if I don't have a suffocating dream once a night, like a dream as if I am suffocating, so Nikki, I can get to bed really early. I can go to bed as soon as my child is down, sometimes before she's down. I can go to bed. I can go to sleep, but I'm right back up.
Yeah.
I just posted about this in real life. And I am checking these numbers. I'm checking on numbers locally. I'm checking on numbers where my loved ones are, you guys. I'm checking on Italy. They've said that we're about 2 to 3 weeks behind Italy. I'm checking on China and other Asian countries as they, come back to life, so to speak. So, and I've become obsessed. I find distractions, but somehow those distractions lead back to this virus. And so I am having a tough time with my own personal care. Plus, I'm a new homeschooling mom. Nikisha, we've talked about this. I'm like, I want to be a homeschooling mom. And we've talked about it for years.
Be careful what you ask for.
It is more than a notion. It is more than a notion. And so I'm doing that 1.5 days per week, and she's figuring the rest out. My 7-year-old is, but at home with my aging parents who are otherwise healthy, but are also in that high risk category for one age, and they're both asthmatics. So one of the big stressors for me, not that I consider myself immune or healthier than, but I'm I go into work every day in a hospital. And although our restrictions are increasing in terms of how many visitors are allowed in the hospital, we've had wellness checks at the door of the hospital for 3 weeks for visitors and for about 10 days for employees now. So every day, all of us who come into the building have to go through the symptoms. Last week, there were 3 symptoms, fever, congestion, or coughing. This week, there are 7 symptoms, including diarrhea, headaches, body aches. So if you've had any of those things and or a fever, you are not permitted to work. You are not permitted to come see your child. This is a children's hospital only. So we're a little bit more contained, more isolated than a general hospital or a birthing hospital. So, and we really just want to keep it that way. They've policies have fluctuated, and I helped with some of them. Fortunately, they've talked about separating moms and babies. They've talked about how many parents can come visit at a time, and then how many parents can come visit in a single day. So, right. So we have, there are parents who only one, infants where only one parent can come during a 24-hour period. Some of our moms are depending on our hospital grade pumps to use. Right. So that becomes the parent who is at the bedside every day, which means that the partner
doesn't get to come.
And possibly weeks without, yeah. So that in and of itself is I just can't imagine that for my own life, and I feel for these parents. And then the other thing that I'm taking home is the idea that exposure is everywhere, right? So I'm saying I'm coming to the hospital with all these precautions, but it's everywhere. It's at the gas station, it's all these places. So I do fear, of course, transmitting something to my child or to my parents, or somehow back to these babies who I barely interact with, and have them have a lesser chance of fighting it than I do. So that is what's all around me more than I think I'm going to get the virus. So yeah.
That's a lot. You said a lot for even to digest as someone listening to you. I can't even imagine carrying that all right now. Yeah. Oh, thank you. That's where she is, y'all. This is a check-in. That's where she is. Angela, where are you? How are you?
So I have been listening to what's going on at my hospital and listening to a lot of people and what's happening at their hospitals as far as walking in the door and being told, no, don't wear a surgical mask because it gives the wrong impression to a patient, to yes, you must wear a surgical mask, to you need an N95 mask. I mean, just hearing the extraordinary variance that's happening around the world and specifically in the United States. And also reading, I'm involved with creating some of the content for LER as well as other organizations. And so indeed, that is something which is challenging. It's imperative to remain up to date, and up to date means changing minute by minute. And yet, and then hearing the injustices that are occurring to birthing families regarding having people present, not just doulas, but also, that one significant other. Hearing those stories just breaks my heart. And then reading about in Europe how, and I'll have to find this resource and pop it into the chat, but how in Europe, how there's an organization that's actually talking about the impact that this separation could have on our new parents as well as our newborns, and the long-lasting impact that it can have not to have that attachment immediately after birth. Think about the 50s, right? When, people were birthing and mothers were knocked out and babies were taken, and the parent didn't see their baby for hours, if not a day. So you know, you think of that, what happened then, and then you see what's happening now. And yes, we want people to be safe, and it's important that they have the right information or good information to make good decisions. So that's just an interesting, you know, that's just an interesting, another layer to it.
Yep.
For sure.
We definitely don't want to go backwards, for sure, you know, with all this
Right.
product.
And it feels like we are, and I
Mhm.
think it's out of fear. And so that's really a challenge. I think that a lot of us are on edge. Like you said, Nikki, you're not going to bed till
Right.
late and not getting a lot of
Yeah.
sleep. I mean, it's everywhere.
Right.
So yeah, and
Right.
none of us are immune if we're doing this work. Angela, did any of the audience check in and see how they're doing?
They did. One person said that they're slowing down. They're not getting as many calls, and so they're trying to do something productive by being home. And in Vermont, they're preparing for the surge. Our positive results are increasing at 12% a day, which may be related to increased testing. And then this person spends some time reflecting on the good in my day, and she empathizes with you, Nikki, because she too is an empath. So positive reflections, walking outdoors, turning off the news, those are all things that people are doing help with all of this.
I've been grounding a lot, like walking outside barefoot a lot, and I don't know how I'm going to get back to wearing shoes after all this is over.
Yeah,
yes,
that's a good one. Some people use water, even if that's just like a soak or a nice long shower if they can't get to water, a body of water. But yeah, I found myself going outside more and just sitting in the sun, just letting the sun hit me, because it's just, you know, you can only be indoors for so long. But really, I'm making it up as I go, right? Every day is like a new challenge, and I'm trying to figure out new ways to kind of meet the part of me that just needs calm and breathing. Jada is an excellent way. So I'm glad you mentioned that.
I think a lot of people are making it up as they go, and I almost want to say like
Yeah.
government officials are making it up as they go. Like, hey, bro, so today, today we're gonna do this and see what happens.
Yeah. I think that
You
is clear in our policies, right? Policies are changing
Right. Yeah,
constantly.
for sure.
State to state, hospital system, hospital to hospital.
right.
There's differences. There's no consistency across the board in terms of how any of us are approaching these in the facilities that we work in. So I want to dig into that just a little bit. Nikki, I think, how many cases are you at now in New Orleans?
In New Orleans, we're at 2270 as of 20 hours, probably 8 hours ago. 2270 in Orleans Parish, which y'all know New Orleans is small, y'all. It's the smallest big city I've ever lived in.
Yeah.
We're at 170 deaths. We are seeing more pregnant women that have COVID. I know that every pregnant woman that goes to the hospital is getting tested. So, for instance, I sent a mother to the hospital the other night. She has hyperemesis. She needed an IV. I have nowhere else to send you. We don't have visiting nurses association here. So, and we don't have home health agencies that do maternal care. So she needed an IV. Sent her to I called the hospital. I'm like, is this where she needs to be? And they're like, well, we don't have another choice.
Wow.
You know, so she gets over there and they test her, and she's like, Nurse Nikki, they tested me. And I'm like, that's interesting. Or is that the new policy? Or what are we doing? And so that is the new policy of testing every pregnant person that comes through there. So that's just something that just went into effect, I feel like last week, because we weren't doing that. We weren't doing that before. So this is where we are right now. As far as visitors and things like that, we're not, if you're COVID, you don't get visitors at all. And it's different policies because we have two hospitals here in our city, and now we have the convention center, which is not a hospital where they can walk up to. It's more so of transferring stable patients out of the main hospitals over to the two birthing hospitals, I should say. So what we've been advising people to do, because within our hospitals, they're very small in themselves as far as maternal care, the ward is. Do they still call them a ward? The department. How about that? The department. And that you may be somewhere else in the hospital, so bring your pump. Bring your pump with you.
Yes.
Right.
We can't guarantee that you have a pump with you. So bring all your supplies. And that's why, you know, before we were always telling people, hey, you know, contact your pump company. And some people would do it, you know, after they got home, it was like, you kind of need to do that at the beginning of your third trimester, to give yourself some time to get that situated. And no, with WIC here, the way our WIC works is you get your pump from the WIC office if you qualify for WIC, and you can't get it until that baby is born. So now we're trying to do a
Right.
quick policy change to switch that up so folks can enter the hospital with their pump and be prepared.
Yeah, those numbers are frightening. So Los Angeles County obviously is several times the size of New Orleans, but
Yes.
we have about the same number of confirmed cases. We have 3,000 as of yesterday. Now that number is expected to go up exponentially. I say that exponentially, to the point where they're saying we'll have at some point about 5,000 a day.
Right.
And that's just, yeah, I can't even, woo. So right now we're at 3,000. We've had 54 deaths as of yesterday. And again, that number overnight will change within the next hour. I'm sure they'll update that and it'll be significantly higher. So we're at a very, very similar place, but probably because of how small New Orleans is, you all a little bit ahead of us in terms
Right.
of
And we had Mardi Gras. Right.
the restrictions. Well,
Right.
yeah.
Yes,
I saw your mayor. Was your mayor or governor?
Latoya, Madam Mayor, yes.
Yeah. who said she would have canceled Mardi Gras had she known
Had she known
that COVID was coming? Yeah.
Right. We can't blame that woman for that stuff.
Yeah.
Come on.
Yeah. So there's a lot of, I think there's a lot of looking back now, a lot of we would have done
Right.
differently had we really had a sense. And I think that, unfortunately, I think that there's places in the middle of the country who are going to have that same sentiment in a month or two. Had we known that it really could hit us, we would have done this differently. Because I got friends in South Dakota who are like, oh, nothing's really happened here yet. We only got one case in the whole county. And I'm like,
Right.
that's not a thing that's going to stay. That number won't stay there.
You're not immune to it. Right.
Yeah.
Yeah. And in Georgia, so the whole state, we're at 4638 for cases and then 139 deaths. But this encompasses Albany, which, if you all are following, is just a freak epicenter for the disease based on a couple of funerals that happened about 3 weeks ago. And it's turning out that just about everybody who attended, or I should say, all of the positive cases and the deaths can go back to one of these two funerals, either somebody who attended or somebody who lives with someone who attended. And people came from out of town to those funerals. So now we're talking about Huntsville, we're talking about Atlanta, we're talking about Florida. Right. And, the pastor, the National Guard was called up to Albany to help with some of this. And so that's where several of I think globally, Albany is number 4 in deaths and number 3 in cases, or something really not what you would be thinking it is for such a small town. So that's a part of our high death toll and positive cases, but also we're Atlanta. I'm in Atlanta, and so here people come from all over to receive care in the big city. This is the big city in the state. Yeah. And we have a governor who has chosen not to do healthcare well over the years, and a governing body over many years that chosen not to do healthcare well. So we are at risk. We don't have Medicaid expansion. We don't have any of the tools that we would need to handle this well. Our governor has also let it be up to the individual municipalities to determine how much they will close down. So we've got neighboring counties, like the 2 counties that make up Atlanta, DeKalb County and Fulton County, have 2 very different policies in terms of a lockdown right now. Wow. And there are streets in the city where one side of the street is DeKalb County and the other side of the street is Fulton County. and their policies change. And I just saw where our governor is making an announcement in the next few hours. So hopefully he will lock down more. But I was also reading where the cases in Tennessee and the cases in Kentucky at one point were quite paralleled. And they have similar demographics, similar governance. The governor in Kentucky closed things down a couple of weeks ago, and Tennessee is still a little willy-nilly, and the cases have skyrocketed there. So we are talking, in addition to healthcare, we're very much talking about policies and actual leadership, individual leadership.
Right.
Yeah, I think we've been seeing, we've heard the term, it's become a part of the lexicon now, flatten the curve, right? So it's the graphics, the charts are very clear, the difference in if you force a shutdown versus if you don't, if you let people kind of continue to, intermingle, the outcomes are drastic and horrific for those places that don't do that.
Right.
Angela, what are you seeing?
So there's a lot of that which is happening as well. And, getting access to pumps, being able to get what they need. Virginia recently locked things down. DC is frankly, so I live in the Washington, DC metropolitan area. Maryland locked things down to travel, I want to say like 48 hours ago. Virginia did it about 24 hours ago. And DC, it started this morning, where if you are found out without going to, your job, an essential job, and or for medical care, there is a possibility of a $5,000 fine and 90 days in jail. So DC is not playing right now. And it's interesting how, indeed, those states where there's no leadership from the highest office, meaning the governor's office, that indeed individual municipalities are, enacting separate, separate requirements. And it's just going to be interesting from an epidemiology perspective and a data perspective. It's really going to be interesting to see about how this is all going to play out. But that's, that's for 10 years from now. That's not for today. We're just trying our best.
Right. Yeah, so Nikki and I were talking earlier about, we have these things and we know what best practice is, right? We knew what best practice was before the pandemic. Like mamas and babies should be together, right? And so what happens when now we see this pandemic happening and now that practice is not being valued as much by the hospitals, and we have to realize that some of our folks, some of these hospitals, became baby friendly last week. Okay, so they weren't even on board.
Reluctantly.
Right. Yeah.
Right. They were looking at, baby friendly, let me get a coin. But now it's like we really have to be baby friendly, and they're like, but there's a pandemic. But let's look at our research that we do have. And when we see articles where we have both the CDC and the WHO and the Academy of Breastfeeding Medicine, and they're all coming together, I think those are powerful documents where we can say, look at these people, ACOG, all of them coming together and coming with one voice and saying, this is the policy, and this actually works in the midst of a pandemic. And yes, we could be, our old way of thinking, we're going to have this just like we have pre-Katrina and post-Katrina here in New Orleans. Y'all better come with us. This pre-Rona and post-Rona situation is that we would go to the, higher ups. It was like, hey, let's have a meeting. Let's talk about these things. That's not actually likely right now. You know what I'm saying? But we do have to, what we were talking about earlier is just like, hey, contacting your department heads, send out an email, get your elevator speech in your email, saying, hey, let me just give you these couple of articles. I noticed that our policies are a little fluid right now with breastfeeding families. This is what the evidence is. 3 sentences, max, guys. And then put your name on it, put your contact information, boom, send it out. Because we do have to be sensitive to the fact that folks are dying by themselves. And while breastfeeding is so important, it's so valuable, we have to be sensitive to all the departments in the hospital that their policies are being hit as well. So that's my take on how to get these policies, how to get these things that we know to be true back into our hospitals in the midst of all that's going on.
I think that's a really important point. Go ahead, Jen.
Oh, I was going to say that, yeah, it is a very important point, and we were actually able to tighten up a couple of policies that were previously fluid. So again, this is a children's hospital where 100% of our babies are sick, and 100% of our babies at some point are separated from their parents, even if it's just in the transition from the birth hospital over to our hospital. And many times it's a parent is not at the bedside for 2 or 3 days. Okay, so that separation piece is not abnormal. As soon as a child gets here, I am able to call, make contact with the parent, and make sure that pumping is happening at regular intervals until they get to the bedside. So now, where we were very loosely, if you want to breastfeed or provide breast milk, then that can we are really saying during this time in our world, we need that milk. Your baby does. And we're going from a health perspective, an antiviral perspective, if not a supply chain perspective.
Yes.
So,
yes.
So on many layers and levels, we are saying we need this milk. We know that we're going to have, Nurse Nikki, I think as you alluded to, we're going to have moms who are going into preterm labor, the stress of this thing. I think we're going to see more and more preterm babies. And so, these babies are really little. We are needing this breast milk. So we have been able to slip in some language that gives the neonatologists, especially, the opportunity or the power to the empowerment to say more forcefully, please, we need this milk from you. So hopefully our numbers will be reflective of that, and more babies will, have access to this milk on, for the duration.
Right. I love that. I'm really excited to hear that, Jada, because so many of the stories that I'm hearing, so many of the experiences of our colleagues have been starkly different, right? So,
right.
And we can't, we have to understand it to some degree. As Nikki said, hospital priorities right now are, people are, they're overwhelmed, they're ICUs, they're running out of beds and on a ventilator. I mean, there's a lot going on right now for them to also take in the, it's still safe to have mom and baby together, or, breast milk is the best milk, or whatever. They may not be able to digest that information right now. And so some of us are really, really, I know, frustrated by the facilities that we work in, frustrated by the leadership, no longer appearing to, or in reality, valuing the dyad, ensuring that the dyad is able to be successful at breastfeeding. And so I want to make sure that we, acknowledge that and share some thoughts on what we can do about that. Nikki had an excellent point. When we were talking earlier, we were talking about, she said, the elevator speech. And I think the reason why we're trying to make sure that we are keeping it succinct is because there's so much other chatter going on, so much going on in the ethos of healthcare in general, not just mother baby care, right? So we want to make sure that if we're communicating up and trying to get a different perspective up the chain, then we do so succinctly and clearly as we can, and be consistent and provide a couple of points of, here's something you can look at when you get a moment, you know what I mean? Some sources, and then just keep going. Because I don't know that we have the luxury to spend a great amount of time advocating right now within our institutions. Families need our attention focused on them. Angela, what's been your experience here?
It's all over the board. I will say that there are a couple of handouts that we put here for people, which literally just came to us last night. It's from a very busy, very large hospital system in the Northern Virginia area. I want to say they have like either 5 or 6 facilities, and the programs, the documents were created by Dr. Karen Bodnar, who is a pediatric hospitalist at Inova Fairfax Hospital. She's also a fellow with the Academy of Breastfeeding Medicine. She also has a podcast along with Dr. Ann Eglash, and they actually have a 2-hour podcast from last week where they talked to 10 different physicians and providers about how they are incorporating lactation care, both inpatient and outpatient, and doing what they can for best practice. The other person who actually created the content that are in the handouts is Diana Gordon. Diana is a certified breastfeeding specialist. She was planning to sit the IBLCE exam yesterday, and so that has changed. So she was also recently in South Africa. She is a certified professional midwife in the United States, and they were stationed in in Nigeria for a couple of years. So she saw that experience and those practices around HIV and other things that happen on that continent. And so it was just fascinating. And I'm grateful that both of them have contributed to the document, which is located in our handouts. So a big thank you to them.
Yeah.
Thank you.
Oh, that's great. I would also mention, I don't know if you have the link to put in the handouts, Angela, but the piece that just came out yesterday by Melissa Bartik, COVID-19 Separating Infected Mothers and Newborns, Weighing the Risks and Benefits. If not, I'll try and get a link to that. It's an excellent piece. It essentially discusses the conflicting guidelines and it's heavily sourced. So if you need some help creating that elevator speech, creating that quick communication that you want to share with your leadership at your facility, I think this is a great place to start. And we'll make sure we get that link shared out as well.
I also want to mention, as far as that's concerned, I've had several people reach out to me to say that the ilca.org/COVID-19, that there are the actual resources, and they've also created some infographics with literally the questions and the answers. And so just as an FYI, the ILCA documents have been exceedingly helpful because they give all of the references, and that's really what hospitals want to do, is to provide that evidence-based care. And that's the challenge right now, is that we don't have a lot of evidence. There are no RCTs, right? You're not going to find those. But what you are going to find is some really well-considered case studies that you can reference, and that at least from those countries that are a couple of steps down the road from where we are.
Right.
Absolutely.
But we also encourage, because we don't have RCTs and things like that, and we're just kind of going from day to day, we do have to encourage common sense, though. And that's always free. So we do have to encourage our hospitals to say, you know what, I trust our lactation department, and that they know, and seeing the lactation professionals as providers of health, because this is a necessity for the babies that we're caring for. So to recognize lactation IBCLCs, lactation specialists in the hospital as healthcare providers, and just being a part of the conversation, being a part of the healthcare team when providing maternal child health is super, super important.
Absolutely.
Yeah.
Angela, what questions? Oh, I'm sorry. No, Jada, and then Angela, feel free to start tossing questions at us. Yeah.
Okay. I was going to say, Nurse Nikki, that I think that this virus, and we all do, is shining the light on a lot in this world, right? A lot of the things, a lot of the work that we already do, a lot of the disparities, as Angela mentioned, a lot of FMLA issues, a lot of everything, right, that we already know has been problematic. One of the I think areas where a light is being shown is how little those outside of human lactation know about human lactation.
Yes.
So this could be our time to shine, where I really do feel like those who are thought to know a little bit of everything are having to come down and drill down on really specific cases and questions, and biology and physiology, imagine that, biochemistry about human lactation and all of that it entails. And there are only worldwide a few of us who deal with it in the way that we do. So I think that appreciation is having to come around for those who are wanting to provide quality care.
Our silver lining.
Absolutely.
Angela, you have some questions for us?
Question was, are hospitals moving to telehealth and are no longer doing in-person outpatient consultations? So what are hospitals doing? I think the answer to that really depends upon your facility. I do know some hospitals who are not allowing any outpatients. So if there's no outpatients being allowed, then, then no outpatients also means those pregnant people that you were able to serve and the outpatients that you were able to serve after discharge. So I think it does depend upon the facility.
Right.
Have y'all heard of anything, Jada? What do you do? Do y'all see outpatient lactation?
Yeah, so we have an outpatient, a standalone outpatient tower, and they are down to 10% right now. And we have stopped all elective or non-essential, as in non-life-saving surgeries in the hospital itself. Essentially, the only department that's performing surgery is the cardiac department. So here we have neonatal intensive care unit, cardiac intensive care unit, cardiac step down. We have oncology, we have transplant units, and then general pediatric and pediatric intensive care. So out of all of those departments, the only cleared on a daily basis to perform surgery is the cardiac unit. Everything else must be a life-saving surgical procedure. And then, as I said, our outpatient services are down to 10%, and most of those are based in either nutrition or infection control.
Yeah, we have no outpatient lactation services here. They're not doing any lactation, outpatient lactation visits. Here we don't. We had those services, and they have stopped all of those services. Actually, I've heard something to the liking of some of the lactation consultants have actually been pulled into being postpartum nurses. So they have dual roles now, just because we're on a shortage of nurses here. Because in our state, we do not employ non-nurses. If you aren't not a nurse, you cannot work in the hospital as a lactation person. So they've been pulled. And so they're referring everyone to outpatient. And literally, I was on a call today, and they said we need all the Zoom meeting IDs for all of the all of the community organizations, so we can send them into the community, because we just don't have the capacity. That's not even on their radar right now. But they are getting calls, but they aren't getting answers. So the community has to kind of find the stuff themselves.
Yeah, I think that's been my experience, or what I've seen the most in Los Angeles is a very similar approach. There's some outpatient things happening, but not a lot, certainly not lactation support. And where there is a need for that, facilities are looking to ways to connect folks to the community to find those via telehealth. And so it's changing the way that we do work here as lactation consultants in the community. But it's also exposing us to a different set, I think, of clients or patients that we would normally we see folks that kind of find their way to us on their own. Some hospitals may have directed to us, but this is different now. We're getting a lot more traffic from hospitals that are turning people away. They just cannot, people are being released from the hospital much sooner after birth.
Yes.
If everything's all right, get out. Take baby, get out, go home. This is where community really steps up to be a resource in a way that we have always been, but to a larger amount of people. So back to the talk we did last week. Angela, you have any different experience?
No, I think that's really pretty accurate as far as outpatients now having to turn to the community. I do know of a relatively innovative hospital here who they are pivoting. So, it's a matter of finding out. All of these hospitals have telehealth opportunities, right? They have them in their electronic medical records or in their electronic, services. And what's interesting is that I'm seeing that some providers are being given this information on how they can perform telehealth, but yet the lactation people are not. They're not even at the table. And so to Jada's point about, you're being asked these things, indeed, it's a matter of being at the table. And that's the most important thing. And it's hard to get at the table when you haven't been there up to this point. And now all of a sudden you see these opportunities where they need infant feeding specialists, which is what a lactation consultant is. And so what I'm hearing from some innovative people is that they're finding out that there are telehealth options available, and then trying to find a way then to elevate lactation services in order to get that same care. I also know of another facility where what she's figured out is she has access to their electronic medical records through a special laptop that she was allowed to take home. And she has access to Zoom, and she can do that on her personal computer. So she is literally set up with 2 computers so that on one side she can provide that care in one, provide the care on her personal device, and then on the other device she's charting, so that she's able to get that information. So she's trying to meet the requirement. And that's what it is. It's a matter of saying, how can I meet these requirements? It's not saying, no, we don't want to do it. No, you need to buy this expensive system for me today. It's a matter of how can we just provide that care? And so this person's finding an innovative way to do that. Granted, she's got the privilege of having a computer at home for her personal use that's not being taken up by her, family members who either need to work and or children who need to school.
Yeah. Right.
But that's one thing that she is able to do.
Yeah. Any other questions?
A lot. So, and so to your point, so this is being recorded, and since this is being recorded, we are going to have, this webinar is going to be up. Some people are asking about in-home telehealth and how can that happen, and whether or not it should happen. And so I put in the chat, I referred people to the LER handouts that Nikki Greenaway actually helped to develop the content for. And so do take a look at those handouts, because they can help you figure out whether or not to do that telehealth visit and or the HIPAA compliant platforms which are available. So
and listen to last week's recording. We talked quite a bit about it.
Exactly. Yeah. So, and I just ensured with our tech guru, Steve, that last week's webinar and this week's webinar are both going to be available on our website. And so you can go back and look at that. It is free for you to listen to. But getting back to the hospital though, what about when you're actually in the hospital, and how do you deal with a parent at the bedside? Right? So the question really has to do with what PPE are you using, and let's say the baby is struggling to latch. What do you do as someone who's at the bedside? Jada, do you want to?
Yeah, so I have used, I use masks and gloves all throughout flu season. So this is before we knew that COVID would be what it was. I train my tech and even fellow lactation consultants to do the same. It's Universal Precautions Plus, and I definitely understand and recognize that, having worked both in a hospital and in families' homes, that there's the clinical stigma, and there's all the, there's something wrong with the baby if you're wearing gloves. It is not that. I'm not trying to be a physician, but really, I just don't want it to be that the baby got sick and they trace it back to, oh, that lactation consultant was over here last week. So that's why I wear masks and gloves all the time anyway. The only thing that we're really doing, so we follow universal precautions. We're washing and or sanitizing in and out. We're wearing gloves. I personally, because again, in this children's hospital, I literally get the closest to parents of any other provider. A respiratory therapist, a surgeon, the neonatologist, the nurse can communicate with the parents without being knee to knee and forehead to forehead with them. So I cannot all the time. So I have general, just again, gloves and masks, not N95, although we have N95 masks available to us. We won't bring those out until we have cases in our area. And so that's what we're doing already. The only thing that we've really added for this time is to wipe down the bottles of milk that we receive before we put them in the freezer. So that's it. Yeah. So, we're reinforcing with the parents, frequent hand washing, but these are practices that we have anyway. frequent washing and sanitization of the pump parts and kits. We already have that in place. We share a campus with the CDC, which is a thing, and so we're yeah. So
Fancy.
we're fancy, right? So we've taken pump part. Most of our parents are pumping, and so we've taken pump part cleaning very seriously for quite some time. Those things are not new. So the only new part is wiping down the bottles before they go into the freezer.
Makes sense.
Yeah.
Makes sense.
That's it. And to the question, though, just to kind of get back to it, just to remember, let's say, Jada, that you don't have a baby who's latching well, or Nikisha or Nikki, what do you do for a baby who is struggling with that latch in those first, 24 to 48 hours? I mean, I have one idea, but what do you all say to do?
We want to hear that idea too. We do. For me, I'm not handling this much differently than before. Well, yes, okay. When I was still seeing people in person, there was a lot of directing without touching, directing without hands on, and keeping a little bit of distance. But in telehealth, this is kind of what we do anyway. It's really trying to hone those skills and directing folks through this lens of what may be mirrored, what not, what what I mean. We talked about last week, trying to make sure that we are using words that they understand and directing them in a way that they can find success on their own without us having to actually be present with them. It's kind of the same thing, I think, in this instance. Not being a hospital practitioner, I'm not now suddenly going into hospital. So I defer the question to those of you who are doing a little bit more of this in person. Nikki?
I would just say the gloves and mask is important, but also I think the mirroring, I even do that in the home. So as you're sitting in front of the client and they're holding the baby and you're holding a prop baby, and just saying, just do exactly what I do. Slow motions, giving them time to adjusting yourself, but also keeping an appropriate but teachable distance from the client is important, because we don't want to offend, right? They really want to master this skill and they don't care. I mean, to some degree, like, I don't care about COVID, like, just show me how to do this so I can feed my baby. So you have to take both of those things into account. Like, I'm trying to respect a pandemic, but I'm also trying to respect the fact that this parent is trying to learn a skill that is usually taught a little bit closer. So keeping that balance there.
Yeah. What were your thoughts, Angela?
The same, so for people who provide community support, for people who have been doing, telephone support for years, that's exactly what you do. In other words, and research even demonstrates to us that the best thing for a practitioner's hands is behind their back. So that, the use of the baby's hands is to find the breast, the use of the parent's hands is to support that and to support the breast, and the use of the practitioner's hands is to go behind your back.
Right. And we talked about that even sometimes with just holding your hands together like this in order to avoid like touching your face and all those things, just finding your neutral and just holding it there just as you're from a respectable but teachable distance.
Yeah. I have started holding my hands. I think that's been quite helpful. I realized a couple of weeks ago that I touch my face about 3 million times a day.
Same.
So holding my hands has been quite valuable for sure.
But you suddenly have the itchiest nose ever, right?
Ever.
All the time. And need to cough all the time.
Yeah.
So another question.
What else you got, Angela?
Yeah, so another question here is, what are hospitals doing as far as whether or not they're separating, parents with babies? And what sense have you gotten just by looking online?
I've gotten a sense that it's really inconsistent. That some are being really, really forceful with, separating immediately, whether, just out of an abundance of precaution. And some are, taking more of a wait and see approach as more data is coming out, but I haven't seen anything consistently across the board. And that I know is really, really frustrating for us.
I have seen those inconsistent policies, but I haven't actually heard of a family where the separation, regardless of COVID diagnosis, has been implemented. So I'd be interested in seeing how far they're going with this. Like I said, I've seen a couple of systems who are saying this is what we will do. I have not heard that it's actually happening. So hopefully some of those systems are falling back. It is actually happening. Oh, wow.
Oh, yeah, it's actually happening here. But it's,
Regardless,
I would say it's like a case by case. Oh, yeah. Yeah.
Wow.
So we have to turn over our rooms pretty quickly. So sometimes it's just the sake of like, we, need this room. Other times it's for the sake of, well, this mom is positive. One of my patients now, she's like, I saw my baby for a second. He's so cute. And I said, is he in the room with you now? She's like, no, ma'am. She said, they took him. She said, I saw him for 5 minutes and she hasn't seen him again since.
Wow.
So, and that was on Sunday.
How are they handling feeding? Are they encouraging her to pump and sending her milk to baby? None of that. Yeah.
Yeah. Wow. That is the fear. I'm
So,
sorry to hear.
To kind of get to that, though, somebody had just asked, for those of you that are hospital-based providers, and I think Nikki and Nikki, y'all can address this as well, how are you empathetically dealing with family restrictions to visitation?
I think part of being in this field, if you are worth your salt, you come in, as empathetic every single day. You understand that these parents' experiences are real and you can relate to them and you can empathize with them. It's heartbreaking, though. It's heartbreaking to watch these types of separations and to know that a family really wanted to be successful at breastfeeding and may not be set up for success from the beginning. And so I think my language around it is to affirm and to encourage, and then to really try and kick the ball down the road a little bit in terms of talking about how this doesn't mean this is not possible to get this right? We can pick this up in a few days when everyone's home, and we can get you two back together, and you can be successful at breastfeeding. Lots of people have rough starts. Lots of people have formula first, but this is not a thing that wipes out the possibility of you being able to breastfeed, and that's my approach, at least.
Yeah, mine's exact same. I try to affirm and make sure to give them tangible resources that they can use and to help them along the way when they leave the hospital, because just to know that their hospital stay is not going to be that long anyway. Now, if they have COVID, then it's going to be, the baby will be given to the other parent, if there is another parent or a support person to take care of while the other parent is hospitalized. But to know that there are resources available in the community. And that's why it's so important, if you are a community-based lactation specialist, to make sure the hospital has your resources, so families aren't falling, not in a gap, but just off a cliff. Like there's no other communication, because the hospital's focus is so inpatient right now. They are disconnected from what's going on outside, literally by parameters of closed doors and temperatures and all those things. So we have to kind of take that step for them and saying, here we are, because they're not going to seek you. Say, like, let me get on the phone and find somebody for you. I don't know if that's necessarily going to happen with the speed.
It's not happening.
That it did happen, if it happened.
If it happened, right? Yeah, I definitely think it has been deprioritized to a degree. I'm wondering, this is what I don't know, for those babies born at baby-friendly hospitals where nurseries have essentially gone away, where are the separated babies going?
I just had that thought before this call. I was like, where? Because we're not using the nurseries.
Right. Unless they're reconverting them. I don't know.
Yeah.
I don't know.
Angela, any idea?
Yes, and that's actually something that Ashley Palmquist brought forward, Dr. Palmquist brought forward in her webinar. If you've got these mandatory separations, where are you going to put the babies? Because you can't just put them in a well baby nursery. So even if a baby-friendly hospital doesn't have a nursery, you can't do that. And so that's why the WHO guidance on, separate the parent and the baby, put them, especially if they are, COVID COVID positive, if the parent is COVID positive, you separate them in that room, right? And you have fewer visitors who, as well as staff going in and out of that room. You've got that negative airflow room, the negative pressure room. So that's what you're doing. And then have them 6 feet apart when possible. And breastfeeding involves masking up and skin to skin and hand washing prior to touching your baby and after touching your baby. And even having maybe a curtain, a sliding curtain between the parent and the baby. So yes, it's sad. And to have a healthy caregiver, so another parent or significant other in the room in order to help to care for the baby, especially if the mother is too ill. And if the mother's too ill, that's a whole nother discussion. But
That's different.
Right.
Yeah. Right.
Well, so that's
I think one of our barriers here is PPE.
Oh, sorry. Angela, was that a recommendation or are facilities putting that into practice?
Facilities are starting to put it into practice. And I think that those are the people where you've got strong infant feeding specialists. You've got strong leadership there who prioritizes breastfeeding and prioritizes the normalcy of breastfeeding and getting that skilled care. But also, in my opinion, you could sell it to your leadership and say, do we have the capacity to separate and put into a negative airflow room a parent and a baby? Do we have that capacity? What does that look like? In other words, help them to think a couple of steps down the road. And that was something that some people are finding to be effective and compelling for their leadership.
Right.
Thank you.
So another question here. So I want to move a little bit towards what to do immediately postpartum. And so Nikki and Jada, I think y'all can help with this, which is how do you do a belly check and a weight check at 3 days postpartum? What are some things that you can do? So I think some of these hospitals who are providing outpatient lactation services, it's to do those two things. And so what do you do in that situation?
Well, a parent can do the weight check. I don't need to necessarily be hands-on for that.
How do you do that?
So in my practice, generally, there's a scale that's available. I think, Nikki, you talked about this in yours as well. There's a scale that's available for parents to come in and use on their own. They don't even have to encounter anyone, and they can do pre and post if they want. They can just come in frequently and check baby on scale and keep it moving. And that's not a thing that's outpatient wise, in the community. It's
we
hard
started
to
that last week. And it worked really well. The COC that was at the weight station that we had, she said it was very quick and easy, and there was no problems there. All the parents, wiped everything down. There was Clorox wipes and all that, Lysol and all that kind of stuff, and they wiped it all down afterwards. So it worked well. Some of the midwives in our city, they were talking about, we use the thing that we have. Can the parent get a scale? Do they have?
Oh, Nikki, I think I'm losing you. Or can you all hear her and see her?
No, I've lost her.
Uh-oh.
Okay. So, but no, those are some things that are really good ideas as well, as far as how to provide the weight check. As far as the belly check is concerned, I really think that is the pediatric provider who needs to take that responsibility. And if that is something that was typically done at the hospital, then it needs to be the pediatrician who is advocating for that service being provided. And so I think that is something which is really important to be mindful of. So belly checks and weight checks, also that podcast I mentioned, the iAble podcast, they actually are doing it where the pediatric provider, they've designated one of their offices to be that outpatient office, and they are having the parent and the baby wait in the parking lot in their car. And then cleaning everything down, and then once they've cleaned everything, then they bring the other parent in. And, one of the MAs or one of the people can actually go out to the vehicle and ask those intake questions, do everything that they need. So, finding really creative ways to be able to care for these families and provide that separation which may be necessary is something which is important. And then the weight check, someone just said, but the weight check needs to be documented in the chart. And so, honestly, I usually empower the parents that I serve. I write down the weights. And so if I'm able to enter the weight, I do so. If not, I contact the pediatric provider to provide that information. And if that's not an option, then give that information to the parent. So the parent can then provide it and give the date, and you can even write it on a piece of paper with your contact information so that then they have that, because they're going to forget. No disrespect to the parents, they're going to forget. And so to me, it's important that all of that stuff is written down, and you can really encourage the parents, both the billing numbers as well as the weight. Encourage the parents to keep that record, write it down, put it on their phone so they have it.
I would agree.
Yeah, there are, our pediatricians here have started staggering well visits and sick visit times. They are also doing as much as they can just from the vehicles. And one pediatrician office has converted well visits after 2 years of age to all telehealth. And they are only seeing well babies from 0 to 2 at the office. But even that will be staggered with sick versus well times.
That makes perfect sense. That makes sense.
Yeah.
I have an infant, so this is really top of mind for me. She's due for a well visit. I'll have to start, reaching out to her physician to say, hey, what are we going to do about this? How does this look in the time of, COVID-19? What are you doing differently? They've been emailing quite a bit, the office, to say, we're taking extra precautions. Give us a call. Don't just show up. All of those things. So it will be interesting to find out how they're going to approach. Have typically been just a regular well visit. Tomorrow she'll hit another marker, and that won't. I'm sure that won't look quite the same. Yeah.
Yeah, we're doing something similar here in that all the well babies are seen in the morning, and then all the sick babies are seen in the evening, and then they are switching it up and cleaning everything overnight, and then they only see well people in the morning. So they start the day off clean and then go dirty and then come back, things like that. So that's how some people are doing it here.
Great. So 2 more questions. I know we've gone over time already, so thank you both for spending another couple of minutes. One has to do with the pumps. So Jada, you mentioned the pumps in the hospital, and if some hospitals I know have rental stations within the hospital, others do not, and there is a shortage of pumps. So how are you handling pumps going, in and out of the room, going to the ICU? What are you all doing, or do you have a rental depot at your facility?
We do not have a rental depot at our facility. We were getting pretty close to it before this hit. We were also getting ready to change out all of our pumps, which would have meant getting brand new pumps and then more pumps per unit before this hit. So that is not happening. We try, though, very hard to have a hospital grade pump at the bedside for every breastfeeding family that is there consistently. So that is in the NICU, and we just about have enough per breastfeeding family. So not all of our babies will receive human milk, but for those who do, we have just about enough so that the pumps do not have to go from room to room during the infant stay. And then we have 2 additional lactation rooms on the intensive care unit that is available if the parents want to leave the bedside or there's a procedure happening at the bedside, or if they just need to take a walk. They can walk down to one of the lactation rooms and use those. Those and thinking through the process, because that is a lot of in and out traffic. Also, hospital employees are able to use those lactation rooms. So there's a lot of traffic. We keep everything in the room that is needed. And this is, again, would you say, Nikki, pre-Rona? We keep everything in the rooms that's needed for the pumps to be wiped down. We don't follow it up. We don't stand there. So we don't know if that's happening every single time. We encourage parents when we introduce them to the room, and of course employees, that there should be a wipe down after and a wipe down before. We don't always know if that happens. So I probably need to tighten some things there up a little bit. And then in our cardiac unit, we have 2 lactation rooms, the cardiac teams aren't as anxious for parents to be at the bedside pumping, just in case anything goes down. So they prefer for them to be in a lactation room. So there are 2 rooms there. That, again, is a high traffic area where the pumps are shared among breastfeeding families as well as staff. So.
Yeah, I recommend, if at all possible, under any circumstances, the family provides their own pump that they can then cart around to wherever they need it. Obviously, that's not going to be always possible. Something that's being mentioned here in the chat that I think is we'd be remiss if we didn't discuss was hand expression, and making sure that families are utilizing that as a very viable means of expressing milk for their babies. Especially when a pump is not available or they don't have one. And the hospital has, like Nikki said, in another wing, in another location, off-site, or, a makeshift L&D area, or, postpartum area, to be able to utilize that as a resource as well. Of course, it comes with its own challenges in terms of storage and, what are we pumping into and how are we making sure that everything is, again, sterile, but certainly is another outlet, another option.
So, Nikki, that's really interesting because I'm encountering 2 things that you said. I'm seeing moms who are coming in with their own pumps. So more than happens usually, they're saying, oh, no, I brought my own. They're not saying, I don't want to use your pumps because of the Rona. But more, I've noticed over the past couple of weeks, they're more than happy to use their own pumps. So that's just an interesting observation. The other is that as much as I teach hand expression as a skill that moms, no matter how fancy they teach hand expression, you have to know to use this no matter what. They're not trusting their hands right now. So they are saying, well, do I need gloves? And am I allowed to touch my breast? Do I need to wash my breast before I get started? Just that level of anxiety. So the education is one piece, right?
Yeah.
But just the level of anxiety around hand expression with their own breasts, with clean hands, right? Some of them feel safer using the plastic flange that they can stick into the microwave. This thing is just.
You know what? That's ingrained, right? So, that goes back to my grad school days where I studied self-efficacy, and many parents just don't believe they're able to do this thing well, right? They don't believe in their own capabilities, and so this is another area where it just kind of spills over.
Right.
And I am amazed by this, but not super surprised, because there have always been, wipes on the market that parents can buy to clean their breast before breastfeeding, so there have been folks, profiting off of those fears. I think it's a great opportunity to educate, do our best to encourage and get parents to try this thing with alongside the teaching, the education of this, that's not how this works. Right?
Right.
That's not a thing you need to be really, really concerned about. Washing your hands actually does take everything off of them.
It actually does.
Yeah, it's trust the soap and water can do their job. And your breast doesn't need that, kind of thing. So it takes us taking a step back and really slowing down and doing a lot more educating than we're used to. Although our jobs are primarily educators and encouragers, even more of that is necessary. And I recognize that and appreciate that it's a harder thing to do in this time when we have less time, less flexibility to really sit with parents and do more than we normally do. But it's could be the difference between them being successful in the end or not. So
it's true.
Yeah, I'd say give it a shot. Thank you for sharing that experience, though.
That's true. And so one last question, and this is going to be something which is going to take all of our skills. There's actually 2 questions here, but one in particular: how to deal with a mom who wants to stop breastfeeding and do formula because she's so stressed.
Yeah.
I'll let somebody else start first.
So I can try, just because I've had the luxury of having this question in front of me for the past 30 minutes. So, if a mom wants to stop breastfeeding, I think it's important to explore why. If she says that she's stressed and she doesn't want the stress to get to the baby, right? I've heard mothers say that, or they're worried about their milk production not being enough because of stress. You know, I talk to parents about how human beings have been stressed for as long as there have been human beings. And feeding at the breast is something which is done. You know, some people say, oh, my milk supply is going to dry up because I'm so stressed. I don't necessarily want to give stress that much credit. There are plenty of reasons why milk isn't there, but, you know, and stress can be one of them, but also really focusing on how important it is to connect with the baby. Yeah. And how that is just so important to have that time skin to skin and to be with the baby. Those are all really important pieces.
Right.
Yeah.
This is Nikki. Hey, guys.
Hey, welcome back.
So one of the things that I say about this stress issue is that, you know, stress is hormone related, and so is breastfeeding.
Mm-hmm.
And once we elicit more of those breastfeeding hormones, there will be enough to either greatly or slightly overpower the stress hormones, right? Mm-hmm. So I take them through this, like, you know, nice and sweet biochemistry lesson, biology lesson. Yeah. But, you know, and I'm like, the breastfeeding hormones are happier than the stress hormones, and they're stronger and can beat them, right? Depending on whatever the level is. But let's get this milk. So I have been over the past 3 weeks or so, nudge, nudge, wink, wink, listen, this is not the time to do something different than provide human milk. We don't know what this looks like over the long term. And again, I'm saying now, from like a supply chain perspective, like we don't know. We don't know where it all falls down. So I just give them the nod. I don't want to scare anybody more than they already are, right? But I do just have to understand that they understand that this is really not the time to give this up if they can at all have the wherewithal, continue the wherewithal to do it. I had actually parent to give up Thursday, or not give up, but she stopped pumping Thursday. Mm-hmm. And I did not know that. So when I talked to Dad yesterday, he, you know, ran down a list of all of the reasons. I hopped on the phone with Mom, who has not been able to come in and visit the baby for a different reason. Mm-hmm. And we walked through the stress of it all. We walked through her total daily volume. We walked through the size and fit of the flanges and the time that it took and all of the things. And I just kept reiterating, I'm not forcing you to do anything. I could not if I wanted to. I just want to make sure that you have all of the information that you need to make the decision for yourself. And we got off the phone with that. Today I came in, Dad brought in about 4 ounces of milk. So, and this is after she's like, huh?
I said, we'll take it.
We'll take it. Yeah. Listen, this is a woman who, you know, 24 hours before was saying, well, I was trying cabbage leaves and I was trying all of these things. Mm-hmm. And so for her to have pumped and brought in this milk or have given this milk, I'll take it. And if she doesn't give another ounce, that's fine too. But she has the information, and she did not have it before. Mm-hmm. She wasn't on my caseload before. She did not have it before. She has it now. What she does with it after that. And I think that that's, you know, pre-Rona, post-Rona, that is all that we can do. Provide the information. Right. Mom, Dad, y'all make the decision.
I agree with that. Mm-hmm. I'm actually really encouraged by that, because you are dealing, like you said, in a situation where parents and babies are separated 100%, and babies are sick. And so that's a whole nother level of, man, this is just too hard. I'll just, you know, let you all feed formula to, you know. And so I'm encouraged that works even in those families that already have a high stress level. So yeah, with the families that I see that are generally healthy parent and baby, it really becomes a matter of breaking down the risks versus the benefits at this point. And like you said, we don't know. Like I definitely am getting contacted by families who can't get that particular formula they always used to get, you know, and then supplies are scarce and oh, should I wean or should I switch brands? Or, you know, that's a real thing that's happening. And so having a ready supply for a baby, I just want to help you make sure you maintain your supply. That's what I want to do today, so that you know that you have an abundance of milk to help this baby. Let's shift our focus away from the stress, and which is heavy, and we're all experiencing it. It's very real. I do not want to negate that at all, but let's shift to this beautiful, wonderful gift you can provide to baby in this moment, in the middle of all of this. And that tends to be helpful. So I think that's it. Angela's got to run. Nikki was having technical difficulties.
I've extended my lunch.
Yeah. Oh my gosh.
This is where our power randomly goes out in New Orleans.
Oh gosh. But thank you all for listening. Thank you for joining the ride. We will be back next week with another. And we think next week we'll talk a little bit more about taking care of ourselves through this, a little bit more of what we did in the beginning of the call, and spend some more time on that. You all also, though, drive what our topics are. So if you submit questions, send them in to us. Let us know what's on your mind. What haven't we covered yet? What would you like to hear from us? And we will get on that for you. We will make sure that we'll do this. We'll continue to do this weekly as long as it makes sense. Just so you know that Lactation Education Resources and Nikki and wonderful, brilliant guests are here for you in this time of COVID-19.
Thank y'all so much.
Thank you.